For those who have been involved in various committees and activity for DHP, I don't have to tell you how much work has gone on over the last 8 or 9 months. For those of you who haven't been intimately involved, please get involved. There are more committees being formed. One committee that needs to get formed that hasn't been even approved by the managing committee yet is a quality committee. So for those who haven't been involved and want to get, this is going to be a great opportunity to do so. We have about 60 or 70 physicians who are actively involved in this process. Something that I have always been told about Doylestown is that Doylestown is unique, and being a little bit cynical and jaded, I've been really not quite sure how much of that is reality and how much of that is our own belief that we're different than everybody else. But the activity over the last 8 or 9 months with DHP has not only convinced me, but it's really proven to me that that's the case. When we started about a year ago to conceptualize a true clinically integrated network with physicians in the hospital working together, we had a plethora of consultants and people who gave us advice, and that advice included start off with the primary care docs, ignore the specialists because they have all the attributed lives. And then we heard, forget about the primary care docs, they're going to do their own thing. You're a hospital, you make money by all the specialty care, you got to engage the specialists, and you got to start with the specialists. I heard people say that, because these are experts, that you got to start off small, take the best performing docs, don't run before you could walk, start with a small group of docs, and then expand it over time. And one thing that I heard very clearly from just about everybody was whatever you do, start the organization, but if you're thinking about having physician participating in the financial value where they're part of the organization, you're never going to get off the ground, it's going to fail. Well, we pretty much, I wouldn't say we ignored all the advice, but we spoke to people in all different parts of the country that had taken this very advice and started with primary care docs, and they were challenged to get specialists on board. Specialist organizations never were able to get primary docs on board, and they used that as proof of the fact that that's why you can't have both specialists and primary care docs and an organization all together. And Doylestown is different because we proved that we can do it differently. We have pretty solid evidence from a variety of people who have really expertise throughout the country that other than DHP, there is no other organization that's a clinically integrated network that includes physicians, primary care and specialists, and a hospital organization, all with an equity ownership in an organization. We are probably the only one in the country who've accomplished this. The one thing we did listen to them is starting small. The one thing that's different is when they said starting small, they were thinking about 30 or 40 docs. Our concept of starting small is with 274 physician owners and over 300 participants, and that's what we consider small. And when we consider the next level of that, we're really talking about doing something that's really special. We have a website that's going up live in the next couple of weeks, and this is obviously not what makes us great, but this is going to be a very important communication tool, not only for all the equity owners and participants in DHP, but also for our payers, for the insurers, for employers and companies that may be interested in doing work with us, and certainly for internal communication. So that's a critical piece of this. I don't want to spend a huge amount of time talking about future perspectives because we're going to hear from the 6 clinical committees that have been working very vigorously over the last 6 months, as well as the work we've been doing through the Del Valle ACO with our medical shared savings program. But a couple of comments I just want to make on a more global. One of the key things that I think that we have the opportunity to accomplish, I think we've already seen. The work that we all do, and this gets into some of the comments that Dave made a couple of minutes ago, the work that we all do is collaborative. We don't work in silos any longer. So what I used to hear is a specialist criticizing another specialty in the hospital as not performing well and chastising them, whether it was ED or radiology or cardiology or primary care. We're beginning to realize that when you chastise another member of the medical staff, we're now all this together. So you're no longer chastising another person in another silo, it's self-criticism. Because the goal of DHP is to create a clinically integrated network, a coordinated system of care, so that we're all responsible for the care of patients we take care of. So no longer is it a radiology or ED, a primary care or surgery issue, it's all of our responsibilities. Because the coordination of care is something that we integrate together. And I'll tell you, I've already seen it. The number of criticism I've heard from patients about one doc criticizing another doc has dropped precipitously. If there's one thing we're going to accomplish, it's to assure that the patients here get coordinated care, and we may not to be able to do everything for every patient, but we're going to decide together what we should do. We're going to choose those things carefully, and the things that we do should have two important pieces. Number one, the quality should be comparable to anywhere else in the Delaware Valley, and that includes specifically tertiary care hospitals. And two, we should be able to do it at a cost lower than those hospitals. That's how we started. That's what we've worked on. We've had a couple of glitches along the way in certain areas, but it's to all of our benefit to assure that we accomplish that. So what you're going to hear now is some clinical activity and some other activities from various committees. I just wanted to mention urgent care briefly, because some of you may not know, and Dave alluded to it briefly. There's been a strong growth of urgent care, as everybody knows. Urgent care is something that we let other people do. We didn't want to do it in the hospital because we didn't want to be competing with the primary care docs. The primary care docs didn't want to do it because they didn't want to compete with themselves. The ER was interested in doing it, but they didn't want to compete. Now we're realizing something. The payers are requiring a different option for patients who have low-level, quote-unquote, emergencies. So we have two choices. Either we let the for-profits do it and only care about the bottom line and not care about our patients and coordinating the communication, or we take it on ourselves. And that's exactly what we're going to do. So DHP has investigated this in great detail. There's certainly a financial opportunity. The feeling is there's not a huge financial return for urgent care, but the organization, Doylestown Health, understands that there's a lot of other advantages to having a retail sign indicating that Doylestown Health is open for business other than on 595 West State Street. So we're looking to do this. Many of you know that physicians have been offered an opportunity for investment. Not quite clear that's going to go, but we have a strong urge and desire to do urgent care in the Doylestown community, in our township, in the very near future. That probably won't be a DHP initiative, but it's going to be a DHP-inspired initiative, and the care is going to be coordinated with the physicians at DHP. This is just a listing, and it's not meant to read. But these are not done as a token. These are meetings that have happened every month since last November. Physicians have been actively engaged, and when you see the activity of all these committees, you will realize that some have been overly aggressive. Some of them meeting twice a month. A couple of the committees have just beginning to get off the ground because creating a provider network is not quite there yet. But we're working on moving forward, and ultimately the goal should be the hats are nice, but when a patient walks into a DHP-designated office, they should know that there's a certain standard they could expect. Not let the magazines be less than 3 months old in the waiting area, but you're not going to get to read it because you're going to be in and out of that office in a relatively short period of time, that the communications between the physicians, not only within the office, but within the network is going to be real, that patients are going to get information, that scheduling appointments is going to be similar, that the care is going to be the same whether it's a cardiology, primary care, or cardiovascular surgery office, that there'll be a certain expectation that we can meet, and if we provide that sort of quality at a value, then we have a really opportunity to survive, and not only survive, but really continue to grow. The financials we saw over the last year that Dan showed is just the beginning of the tip of the iceberg of what we could accomplish. It's no surprise that you'll see from the contracting committee already 2 contracts signed, relatively small, but an opportunity to sign a Tandem agreement with potentially millions and millions of dollars of upside and downside risk, with a strong confidence that we could perform well is just demonstration of what we could do.